Assalamu alaikum wa rahmatullah. Welcome to the last lecture. So we made it to this day. Today, inshallah, I'm going to discuss with you a very important topic, the analgesics and the antibiotics that we commonly prescribe in dentistry. The objectives of this lecture, first is to know the most commonly prescribed medication, including the analgesics and antibiotics, and also to make sure that you have the adequate knowledge about the mechanisms of mechanism of action of this medication and the doses, the precautions that you need to take while prescribing this medication. So this lecture is going to be divided into two parts. The first part I will present to you the analgesics, and the second part will be for antibiotics. Starting with the analgesic part, during the last couple of lectures we discussed the dental pain, the main cause of dental pain, which was inflammatory. So we had pulpitis, we had periapical periodontitis, so there's an inflammatory action. And obviously if you want to relieve the pain, then you need to reduce the inflammation. And this is why we tend to use sort of anti-inflammatory medication to control the dental pain. The pain could range from mild pain, like the one related to reversible pulpitis, or after dental treatment like doing a filling, so this would irritate the pulp. You might like to prescribe some anti-inflammatory to reduce the patient's pain after, for example, amalgam filling. Or sometimes it might be so severe pain, like after third molar extraction, or maybe minor surgical procedure, or acute irreversible pulpitis or acute apical abscess. So these are severely painful conditions that you need to prescribe stronger medications. So we will go through the range of analgesics that you can prescribe, starting with the non-steroidal anti-inflammatory drugs, which is the mainstay treatment we tend to use as a dentist. So let's see here. You need to know this cascade very well, so you can understand the mechanisms of action for the non-steroidal anti-inflammatory drugs and understand the reason behind the side effects that might develop. When we have a tissue injury, when the phospholipid bilayer of a cell is cut or injured or attacked, it will produce arachidonic acid. The arachidonic acid would be converted into these substances using the cyclooxygenase, or would convert into leukotrienes by the lipooxygenase enzyme. We have two types of cyclooxygenase enzymes. We have COX-1 and COX-2. The COX-1 enzyme is usually present in our body. We call it constitutive, which means that it is always present. The COX-2 is only present during inflammation, so we call it inflammatory COX-2 enzyme. In the constitutive COX-1, it's very important because it converts the arachidonic acid into certain types of prostaglandins. These are physiological prostaglandins, and they are responsible for protecting the lining of the stomach, and also they are important for regulating the function of the kidney. So these are sort of desired effects of the prostaglandins that we need and we require. The second thing is formation of the thromboxane. Thromboxane is the main substance that is responsible for platelet aggregation and vasoconstriction. So as the name implies, this like thromboxane, so it is for making a thrombus related to aggregation of platelet. So this is the constitutive part. This is that is always present. There is COX-2 enzyme that is only present, only produced when there is an inflammation, and it produces different types of prostaglandins. We call these inflammatory prostaglandins, and they are responsible for the inflammation, the vasodilation, the pain and tenderness, swelling, and fever. So it affects the central nervous system, affect the hypothalamus that controls the body temperature. So the signs of inflammation are related to COX-2 enzyme, which is only present whenever there is problem, there is inflammation. Prostacyclin is the counterpart of thromboxane. So as thromboxane tend to induce thrombus formation, platelet aggregation and vasoconstriction, prostacyclin, it inhibits platelet aggregation and vasodilation. So when we use NSAIDs, we are actually blocking both COX-1 and COX-2. Our aim is to reduce the inflammation. So COX-2 would be prevented and we would reduce the inflammation. This is a good part. But the bad part is we also are inhibiting the COX-1, which is useful. So we reduce the protection of the gastric mucosa, and this is why NSAIDs affect your stomach, and also it affects the kidney function. And this is why we do not prescribe NSAIDs for a long time for patients with hypertension or with patients with a kidney problem. So when we do prescribe NSAIDs, although you get this beneficial effect that would reduce the inflammation, would reduce vasodilation, reduce pain, reduce swelling, reduce fever, but it will also reduce the protection of the gastric mucosa and the kidney. Regarding the platelet effects and the thrombus formation effect, it will block both thromboxane and prostacyclin. So it is a neutral. It would not affect anything regarding bleeding. So this is regarding NSAIDs, and this is how it works. For the steroids, for example, it works somewhere here. So it will not just prevent the inflammation induced by the COX-1 and COX-2, it will also prevent the inflammation caused by leukotrienes. So this is why steroids are more effective than NSAIDs. And when we have a severe inflammatory condition, we tend to prescribe steroids rather than prescribing NSAIDs because it has a wider and broader effect. So let's start with describing some of the examples of the NSAIDs available. Salicylate, which is the oldest medication, has been present to relieve pain, which is aspirin, and it is acidic substance. It's acetyl salicylic acid. So the main concern is the GI integrity and the stomach health. And recently there is a form of coated aspirin and buffered aspirin, which provide more protection to the stomach. It is very effective and quick action, like in 20 minutes you can get the relief by the salicylic acid. Salicylates, we will discuss the pharmacological effects as an example of all NSAIDs. So all NSAIDs share with salicylate their effects of anti-inflammatory, analgesic, antipyretic, and antiplatelets. The anti-inflammatory effect is by inhibiting both COX-1 and COX-2, and remember we said the COX-2 is the good part that we want to prevent during inflammation, or is the inflammatory part that we want to prevent by blocking. Unfortunately, it also blocks the COX-1, which is effective for protecting the stomach and the kidney, but we will lose this as well. And this explains the side effects of the medication. The analgesic effect, it usually is useful for mild to moderate pain. Antipyretic, which means relieving the temperature, and this is because it inhibits prostaglandin synthesis, which modulates the thermostat in the hypothalamus. So this would lower the body temperature. Also, it reduces the fever by inducing vasodilation, which would enhance sweating, and this would manage to reduce the body temperature. Regarding the antiplatelet effect, remember that we stated the NSAIDs, they block both COX-1 and COX-2, so they block both the thromboxane that enhances thrombus formation and the prostacyclin. So it does not really affect the bleeding. However, platelet, if taken at low dose, it has the ability, or it would affect mainly the thromboxane and platelets and aspirin. And aspirin this is a feature of aspirin that is not present in other NSAIDs, that it can irreversibly bind with thromboxane and inhibit it and prevent platelet aggregation and prevent vasoconstriction. This is why it is used at low doses to reduce thrombus formation or clotting of the blood. This is a feature for the aspirin, but it is not present in other NSAIDs. Talking about adverse reaction, the GI is the main one for the aspirin because of its acidity and because of its effect on the COX-1, bleeding as we stated, which could be beneficial if you want to reduce the clotting factor or clotting effects in the general circulation, but it might be a problem if, for example, after surgery you don't want to prescribe high doses of aspirin that will enhance bleeding at the site of surgery. Ray's syndrome, which would affect the brain and the liver in children, particularly when they are affected with a viral infection, and this is why we do not prescribe aspirin or any NSAIDs for a child with a viral infection. If a child had a common cold and you want to reduce the temperature, reduce the pain of this child, do not use NSAIDs. We tend to use paracetamol, which is a different group, which is a non-NSAID medication. So it is always advised to avoid NSAIDs for children below 12 years old. Hepatotoxicity and renal toxicity, mainly renal toxicity as it affects the COX-1, and hypersensitivity in some patients, particularly asthmatic patients, because it is affecting the prostaglandins and leukotrienes, and so it should be avoided for patients with asthma. Other types of NSAIDs, the propionic acid derivatives, which is the most famous pink tablets, the ibuprofen. Ibuprofen is the most commonly prescribed medication for pain. Usually we prescribe it at 400 milligram every 4 to 6 hours. It is over-the-counter medication, so it does not need prescription, and the dose should not exceed 1,200 milligram a day. And of course you can go higher if you are doing a prescription for a patient. So you can prescribe, for example, up to 3,000 milligram of the medication. But this is considered to be a very high dose and it should be only for a short duration and should provide the stomach protection by prescribing proton pump inhibitor. I like topical medication. The topical medication goes straight to the point, and example of topical medication, this is the ketoprofen. Of course, you cannot prescribe topical medication for oral condition, but you can prescribe topical medication for facial conditions. For example, if the patient had a joint pain or had muscle pain in the neck and in the shoulders, for example, you can prescribe ketoprofen, which is a very potent medication. It belongs to the same family of the propionic acids. Very effective, and it goes straight to the point. It does not have the side effects. It does not affect the stomach, so it is a perfect option. Orally, we go, for the dental pain, we go for oral tablets. Very important point here is that over 600 milligram of ibuprofen, you would not add more effect. There is sort of a plateau effect So as you increase the dose, you will get higher effects. So 400 is better than 200 milligram, 600 is better than 400 milligram, 800 milligram, it would not provide any extra advantage after the 600 milligram. And this is why I do not like using 800 milligram ibuprofen. I never prescribed it, because all what you do is just increasing the side effects. You are not increasing the medical effect of the medication. It would not improve, it would not increase beyond the 600 milligram. So make 600 milligram is your highest prescription dose for the ibuprofen. Do not go for 800 milligram, although they are available in the market. One point here that I wanted to mention is the anti-inflammatory effect of the propionic acids, or for NSAIDs in general. You require a higher dose than what you need for analgesic dose. So 400 or 600 milligram might be adequate to relieve the pain for the patient, but for anti-inflammatory effect you require much higher doses. So instead of prescribing, for example, 400 milligram as needed to control pain, if you have inflammatory reaction, for example, if you have osteoarthritis in the joint and you want to relieve the pain, 400 milligram as needed would never be effective. You need to prescribe it for higher dose and for longer duration. And usually I do prescribe it for 600 milligram 3 times a day for 2 or 3 weeks. This is a very high dose, and the patient should stick to it. So because it requires about minimum 2 weeks to start its anti-inflammatory action in the joints. So I tend to use it for some of my patients, and I usually prescribe it with proton pump inhibitor if I have to, and prescribe it at 600 milligram 3 times a day for 2 weeks or for 3 weeks. So the anti-inflammatory action of this medication, it requires higher dose, longer duration than the analgesic effect. You can get analgesic effect from 200 milligram, but you will never get anti-inflammatory effect, potent anti-inflammatory effect at this low dose. Other group that belongs to the NSAIDs is the pyrolytic acid, which is the famous well-known diclofenac or Voltaren. Diclofenac is the generic name of the medication. And we have diclofenac sodium, which is the tablet form, and also it is in IM injections that provide a faster action than taking it orally. And now we have the diclofenac potassium. Diclofenac potassium, it is absorbed faster and it has a faster action than diclofenac sodium. And these, well-known sachets available that you can dissolve in water and drink. And 50 milligram is very good dose. Usually I prescribe 50 milligram twice a day. This would be enough to relieve the pain. And another advantage of diclofenac is that it has a longer duration. So in ibuprofen, you need to prescribe it 3 times a day, while in diclofenac 2 times a day is adequate. You can get a prolonged action with diclofenac. Now, because of the side effects, of the GI side effects, they thought, okay, we want the anti-inflammatory action. We don't want to affect the COX-1. We don't want to affect the stomach lining or the kidney function. We just want to inhibit the COX-2. And this is here where the pharmaceutical companies start to work on modifying the NSAIDs by producing a selective COX-2 inhibitors. They thought it's a great idea. This was good news for all patients with osteoarthritis and rheumatoid arthritis, as it relieves their pain without affecting their stomach. But the problem raised when we inhibited the COX-2 and inhibited prostacyclin, which reduces the platelet aggregation and reduces the vasodilation. And we allowed the COX-1, so we protected the stomach, we protected the kidney, and we allowed thromboxane, which induce thrombotic and clotting events. So what happens by inhibiting the COX-2 and allowing the COX-1 is that the balance was tipped toward the thromboxane and more thrombotic events took place. Several patients suffered from cardiovascular complications, thrombotic events, and most of these medications were withdrawn from the market. And the only one is still available is celecoxib, which is a Celebrex, and this medication, it is a selective COX-2, but it does not, it's not as bad as the rest of the coxibs, so it is still available in the market. Sometimes they prescribe it and prescribe aspirin with it, so it would, control the thromboxane effect. So still it is available. You can prescribe it for your patients who suffer from GI pain. It can do the job. I mean, if you are prescribing it for dental pain, you don't need to use it for a long duration, so it would be safe to prescribe it for patients. Make sure that your patient is not a high-risk patient, does not have any cardiovascular problems or thrombotic problems. Then it would be safe to prescribe celecoxib or Celebrex. Okay, and the dose is 100 milligram. It would be adequate as needed, or BID if the pain is more severe. So that was regarding the NSAIDs. The other group is acetaminophen. We love acetaminophen. It is very potent analgesic, antipyretic, but it's not anti-inflammatory. So, and it does not have antiplatelet effect. But it is very good analgesic and very good pain antipyretic. Also, it does not have the side effects of the GI. It does not affect the kidney, but the problem is taking higher doses of acetaminophen would affect the liver, and at high doses it might be hepatotoxic. Recently, they decided to reduce the dose of acetaminophen in combined medication. There is lots of medication in the market that is acetaminophen combined with aspirin, or combined with opioids, combined with caffeine, like for example Panadol Extra, it is combined with caffeine. So acetaminophen, you'll find it with lots of over-the-counter medication because of its safety. They tend to use like 500 acetaminophen and combine it with aspirin, combine it with caffeine, because of the hepatotoxicity, and this had led to overuse of acetaminophen. The pharmaceutical companies, they were obliged to reduce the dose. Instead of 500, they are using 350 milligrams of acetaminophen and combine it with other medication. So acetaminophen is a good choice, and definitely is good for children because it does not have the complication of Frey syndrome or the risk of Frey syndrome. And we love actually acetaminophen. Now, it does not have the anti-inflammatory effect. So in dentistry, as we said, most of the pain are related to inflammation. So we tend to prescribe more the NSAIDs. Well, I would love to prescribe NSAIDs. If you need higher doses, I would combine both. As I'm here, we are. So I'm going to combine both if I need higher effect of analgesia. So here, for example, if in a case of a mild pain, I would use low dose of Profen as needed. If NSAIDs are contraindicated because of a GI problem, because of allergic reaction, we can use paracetamol. or acetaminophen. So paracetamol and acetaminophen is the same medication. Paracetamol is the British version, and in the US they do not know paracetamol, they call it acetaminophen, so it's the same. And for moderate pain, you can increase the dose of Profen. Sometimes we have you can combine Profen with other medication. Rivacod is a combination of paracetamol and codeine. So this would even add opioids to the analgesia. And if you have severe pain, here I would love to use both, combine different medications with different mechanisms of action, so you would reduce the side effects of all. So here you can use Profen, and whenever you are having a severe pain, do not go as needed, go by clock. So do not prescribe the medication like whenever you have pain. You don't want to end up catching up with pain, you want to go ahead of pain. So when you do the dental procedure and you expect severe pain, you ask the patient to take the medication as soon as he is out of your clinic, before the anesthetic effect resolve. So he would have the anti-inflammatory effect once, it requires 30 minutes. So as the anesthetic effect resolves, he would be, the pain would be reduced. So start with prescribing NSAIDs, and you tend to use it like at every 6 hours, for example. Then you can add like ibuprofen, and after 3 hours you take paracetamol, then 3 hours you add ibuprofen, another 3 hours you add paracetamol. So you cover the patient for the first 2 days with this regimen, and this would reduce the pain complaint of the patient. Also, it will improve the outcome of your treatment, particularly if it is RCT or surgical procedure. So the details is given here.